So hello everybody, good morning. Today we'll finish our head and neck cases, and let's have a look at this image, this head CT scan. And you see that you have to see symmetrically the left side and the right side and decide what is abnormal. So as the arrowhead shows, this is the abnormal area, you see. And this patient had a 4-month history of increasing oral pain and dysphagia for solid food. So this is the mass, and it comes from the left posterior base of the tongue, and you see that it extends into the soft tissue. This area here, which appears dark, corresponds to an area of necrosis. So if we have a mass lesion that appears to be necrotic, this is suspicious for malignancy, because malignant neoplasm can become necrotic because neovascularization is not enough to give enough blood supply to malignant cells, and they become necrotic. It's not for good that they are destroyed. It means that they are biologically aggressive. Of course, you should take into account that if the necrotic lesion affects lymph nodes, this is not necessarily a sign of malignancy. Why? Because quite a lot of inflammations in the lymph nodes, known as lymphadenitides, are necrotic without being malignant. There is a possibility that a lymphoma shows necrosis, but it's much lower than that of other neoplasms. So when you see necrosis in lymph nodes, it's not necessary a sign of malignancy. When you see necrosis in other mass lesions, it's a sign, suspicious, it's not diagnostic, of malignancy. So in this case, we have a malignant tumor arising from the oral mucosa of the tongue specifically. What kind of epithelial tissue is lining the oral mucosa? In most of its parts. What kind of epithelium? Squamous epithelium. So, since it is of epithelial origin, it most probably is a squamous cell carcinoma. That's what we expect to see if we take a biopsy. And in this case, the histologic sign of malignancy is frank, true invasion. Remember what we said in our last lesson of some lesions that appear invasive but aren't invasive, such as the pseudocarcinomatous hyperplasia, a rare lesion, fortunately rare, which, however, we must have into account so as not to overdiagnose invasion. So, this is what we expect to see from the biopsy. And this is the survival. It's quite good when the cancer is of an early stage. And it is of interest that in a subset of squamous cell carcinoma of the oral mucosa, human papilloma virus can be involved. This is a separate entity with a distinct prognosis, thus forming a distinct prognostic group. So in some cases, it's clinically important to give this information to the clinician if it is an HPV-related squamous cell carcinoma. And there is a common immunohistochemical marker which is overexpressed in HPV-related cancers. This is P16. P16. It is mainly used, as you can understand, in cancers of the cervix in women to see if it is directly related to HPV or if it is not related to HPV. This is of crucial importance there. But also, it is of importance in these cancers, in cancers of the oral cavity, squamous cell carcinomas. Here we are. Now have a look. It's something interesting. Here we have a true invasion. That means there is no way that these islands of cells are not invasive. They are too deep in the dermis to think that they may be connected with the overlying, the lining squamous epithelium. However, in this image, it is of interest that the overlying epithelium, first of all, is intact. Why do I say this? Because many carcinomas, when they arise from a mucosa, they become ulcerated. They destroy the lining epithelium. This is not the case here. Can you show me where the lining epithelium is in this image? Who can show me? Here it is. That's right. Yes, the arrow shows it as well. And what is of interest? Have a look at the lining epithelium, and you can see the cancer invading in the stroma. Okay. What is of interest? Is there anything wrong with the lining epithelium? I'd say no. Because what could be wrong if you have a tumor-adjacent epithelium, an epithelium neighboring the invasive tumor? What would you expect? What would you expect to see there on the microscope? Is there a lesion that would be logically expected to be detected in the neighboring epithelium of an invasive carcinoma? What pathologic lesion would that be? What pathologic lesion would that be? Which would be a precursor to invasiveness. Which we talked of this lesion. Yes, we talked of this lesion in our previous lesson. Yes. Dysplasia or in situ carcinoma. These are pre-invasive neoplastic lesion, intraepithelium, within the lining epithelium malignancies. However, this is not the case here because the overlying mucosal epithelium is totally normal. There are no signs of at least high-grade dysplasia. So what does this show us? That dysplasia is most often a precursor lesion, but it's not always. Sometimes cancer may develop through normal appearing epithelium. Of course, it may appear normal morphologically, but you have not searched for any genetic alterations which are existent. However, they have not yet given the respective morphology. So it is not absolutely necessary to find dysplasia in the neighboring epithelium of cancer. But most times you do. You find dysplasia there. And what is another thing that you should take into account? Since the epithelium appears normal, it's not ulcerated, it is intact, and you see cancer underneath, what does this make a problem for the surgeon? The surgeon takes a biopsy or wants to remove all the lesion. So what is of crucial importance for you as a pathologist to tell him? If his margins are tumor-free. And what does this picture show? The lining epithelium can be normal, so macroscopically the area would appear normal. However, there is cancer underneath. So how can the surgeon have this information during the operation? Because he wants to know if he has removed the cancer in its entirety. How can the pathologist help him in such an instance. How can he help him? How can the pathologist? What will the surgeon take during surgery to see that he has removed all cancerous tissue? What possibility does he have? This is frozen sections biopsy. He'll take a biopsy during the surgery, send it to our lab, and we'll take frozen sections and answer, is it cancerous? Then you should cut further. Is it okay? That means it's safe. In case he wants to know the distance between the cancerous cells and the surgical margin. This is of crucial importance so as to predict if the tumor is going to reappear, if he will have a local recurrence, but it is of crucial importance to see how much he can remove, how much tissue he can remove so that his excision is safe. And bear in mind that we are talking about an area where if you remove too much tissue, the patient will be disabled. You'll cut a part of his tongue. This is a very crucial operation for his post-surgical condition and quality of life. So he has to cooperate with us, with the pathologist, so that he makes the right excision. Not too much, not too little. Yes?
But how would we know that the margins are true since we have normal appearing epithelium?
Yes, that's why he checks it with a biopsy, because he cannot know. In this area, you see normal appearing mucosa macroscopically. However, there is cancer underneath. True invasive cancer. You see all these islands of squamous cells are frankly invasive cells. So that's the way to check it. You'll take a frozen section biopsy, and we have to answer within 10 minutes because the operation has not finished, okay? So that's how we'll check this. And of course, this is squamous cell carcinoma, and it can give metastasis. You can see some genetic alterations that are expected in such cancers. And of course, you have a local spread, like all malignancies, metastasis in lymph nodes, and distant hematogenous metastasis to the lung, liver, and bone. Now, have a look here. Where is this lesion located? The patient had a 1-year history of right jaw pain. And you remove this lesion, and this is a lesion that is locally destructive. That means it destroys tissues on a local level and needs to be widely excised because it may recur. However, it does not metastasize. So it is not a malignant lesion. It does not have metastatic potential. However, it has a potential to recur. And this is an odontogenous keratinocyst with a lining epithelium and locally aggressive behavior. And it can be encountered within the Gorlin syndrome phasm. Here is another lesion in the mandible, which has a potential of local aggressiveness. That means it can recur. It destroys tissues locally, and it does not metastasize so often. And this tumor, here we have it in the mandible, it can displace because it is locally destructive, and it grows. So it displaces the teeth most often, and it comes from the organ of the enamel. That means this is not a squamous cell epithelial lesion. So the normal enamel organ has cells known as amelloblasts. So this is an ameloblastoma. This is a tumor which can arise on the background of a dentigerous cyst, and it requires wide excision as well as the odontogenous keratinocysts that we previously saw. So these are some lesions of the region in which the surgeon must remove enough amount of surrounding tissues so that they do not recur locally. That was what we have to do of lesions of the... let's have a look here. Close to the midline, we can see this lesion. The fact that it has this consistency in its center. You see, here is the lesion. It's a neck mass. It's close to the midline, and it has this configuration radiologically. What can that be? What can that... Yes? One thing is that, taking into account this consistency, this could be necrosis within a lesion, forming a cavity, a cavitated lesion. This is one thought. It's logical. What else can you think that it might be, and not be a mass? It could be a cyst, and that's the cavity of the cyst. So, if you remove this cyst, you'll see that it can be related to the hyoid bone. This is the lining of the cyst. So what epithelium is this? The lining epithelium. What epithelium is this? Can you identify this lining epithelium? This is the lining of the cyst. All right? What epithelium is this? What do you think? Is it squamous? No, it's not stratified. Cylindrical epithelium. It's the same from the upper respiratory epithelium. This is the common pseudostratified, cylindrical, or respiratory type epithelium. What else is there? These cells here in the stroma, what are these cells? And they have a nodular configuration. What can these cells be? Lymphocytes. And they most probably make a follicle. So we have lymphoid tissue. So if it was not close to the midline, but somehow beyond, it could be a lymphoepithelial cyst. However, it's not the case here. Lymphoepithelial cysts are described in the region, not so close to the midline. However, there is one histologic finding that makes us understand the diagnosis, identify the cyst properly. And it's this tissue here. What sort of epithelium is this? And what does it form? Have a look here. These structures here. What sort of epithelial tissue is this? On the bottom, at the bottom. What can this be? Yes. What epithelium is this? Yes.
It's simple.
A simple epithelium forming, yes, follicles.
Like
you can say glands. It won't be wrong. But this configuration, taking into account the anatomical location of the lesion, which organ makes you think?
Thyroid.
The thyroid. This appears to be thyroid follicles. So you see glands having this colloid content, and you are close to the midline. So it's most probably thyroid tissue. So this helps us make the diagnosis of a thyroglossal duct cysts. And from embryology, you remember the direction which which the thyroglossal duct follows. And it's possible that it should be that due to its midline location. So, and it can also be detected in a direction upwards, as you can see here, near the mouth. And for this epithelium to become malignant, it's not so possible. However, there is a small recurrence risk with incomplete resection. So what we see today is that in benign lesions, sometimes complete resection is mandatory so that they do not recur, because all these benign lesions, being benign, do not metastasize. However, they can recur locally. So a benign lesion should be properly excised by the surgeon. Where does this tumor-like lesion is located? Have a look here. It's near this patient's carotid. And have a look at the histology. It's close to where the carotid gives its two branches, internal and external. And have a look at the cells forming this tumor. Do they appear, is there a considerable degree of nuclear pleomorphism, or do the cells more or less look like each other? For example, when you examine a neoplastic population, if you have evidence of pleomorphism, different sizes of nuclei, different shapes of nuclei, you can hypothesize that it is a malignant neoplasm. If you have a uniform appearance of neoplastic cells, it favors a benign lesion. There are exceptions. There are exceptions in this rule. However, that's the rule. So have a look at these cells. Do they appear benign or malignant with regard to their nuclear characteristics? What do you think? Do the neoplastic cells look like each other, or do they differ from each other? What do you think? They look like each other. So it's possible a benign neoplasm. And remember what we said from the previous semester. If a neoplastic lesion consists of homogeneously appearing cells, what differentiation is suspected? What differentiation is suspected? Because this forms a category of neoplasms which can be either benign, like this one, or malignant, like other neoplasms. And they have homogeneously appearing cells. The cells look like each other generally in low to medium magnifications. What differentiation is expected if you see such homogeneity in a neoplastic cell population? Yes?
High differentiation.
Eh?
High differentiation.
So, if cells look like each other, it's not a sign of high grade. It's a sign of low grade. However, I do not ask for the degree of differentiation, but of the type of differentiation. What can you think of that? Yes? So, it can have a glandular configuration, and this is compatible with epithelial origin. Not always. Immunohistochemistry will show. But when you see a neoplastic cell population with homogeneous cells, you suspect neuroendocrine differentiation. This may be a neuroendocrine neoplasm. Neuroendocrine means neoplasms who derive from neuroendocrine cells, which can be dispersed throughout the body among mucosal surfaces, for example, gastric, intestinal mucosa, and these tumors are called neuroendocrine tumors, formerly known as carcinoids. The same in the lung bronchi, carcinoid of the lung. In this case, these neuroendocrine cells form a benign neoplasm, which is morphologically identical to a tumor of the adrenal medulla. Not the cortex of the adrenal, the medulla. Which is this tumor, since we have studied endocrine pathology in the previous semester, which is a tumor of the adrenal medulla. That means from cells secreting catecholamines. Catecholamines. Which is this tumor? Yes. The pheochromocytoma. So this extraadrenal pheochromocytoma is called paraganglioma. It has neuroendocrine differentiation. However, it does not have epithelial differentiation. So it is not a carcinoid. It is not a neuroendocrine neoplasm, because such neoplasms would be of epithelial differentiation as well as neuroendocrine differentiation. This one is only neuroendocrine of neuroendocrine differentiation. So this is a paraganglioma. And this is, they form these nests, neuroendocrine cells form these nests here, you see, and they have a supportive network which stains for S100 protein immunohistochemically. So these are paragangliomas throughout the body, And of course, they can secrete catecholamines, which especially when located in their logical anatomic location, that meaning the adrenal gland medulla, what symptoms will they cause to the patient? Since they secrete catecholamines and enter the circulation, which is the main symptoms a pheochromocytoma causes. What will they cause to the patients? Since they secrete catecholamines? What? What will they cause? What symptom? Hypertension, yes. He have attacks of hypertension, this patient. Not so often from paragangliomas, but from pheochromocytomas, it's a most important sign that these patients show. Yes?
Can you explain again why they are not considered to be carcinoids instead?
Yes. Carcinoids, neuroendocrine neoplasms of epithelial differentiation, should express markers of epithelial differentiation, cytokeratins, most commonly with a dot-like pattern, along with neuroendocrine cells. Paragangliomas express only neuroendocrine cells, neuroendocrine markers, synaptophysin, chromogranin A. Yes, they do not express epithelial markers, no cytokeratins, no epithelial membrane adjuvants. So, morphologically, they appear the same. They appear the same. So you perform immunohistochemical stains against neuroendocrine markers, they are positive. So this is neuroendocrine differentiation. Stains for epithelial derivation are negative. So it's not a carcinoid. Next case now. Now we go to salivary gland tumors. Of course, we have major salivary glands, means the parotids, the submandibular glands, the subglossal glands. These are double. And you have minor salivary glands in the base of the mouth and throughout the upper respiratory system. So a neoplasm of salivary glands can appear anywhere in the head and neck region. So, and this is important to differentiate it from other neoplasms from lining epithelium. What epithelial tissue forms the salivary glands? What type of epithelium is it? Glandular. They have some acini and some glands which are called ducts in this case. Why? Because they have double cell lining. The luminal cells looking at the lumen and the myoepithelial cells which are necessary to contract so that saliva reaches the mouth. This is the ductular structure. Two types of cells. So, salivary gland epithelial tumors may consist either of both types of cells, lining cells, luminal cells, and myoepithelial cells, or of one type of such epithelial cells, either only myoepithelial or only luminal. And the benign tumors are called adenomas. The malignant tumors are called carcinomas. They are of epithelial origin. Having a look at this tumor, it's quite big. Have a look at its consistency. It's not uniform. There are some areas within the tumor parenchyma that give a different signal. However, it is rather well demarcated. So it's probably benign. It's a tumor, I think, of the parotid here. And the most common salivary gland tumor is the pleomorphic adenoma. And let's have a look. Here is another tumor. Quite well circumscribed, this one as well. This is a pleomorphic adenoma. And let's have a look at its histology. And you should always pay attention when you do surgery in the region not to cut the facial nerve. In case that there is a malignant tumor, a carcinoma, and destroys the facial nerve, then you must find some sort of a graft so that the patient won't become unable to do all the functions of the facial nerve. It means it's like you cannot, if you have a problem on the facial nerve, you cannot do that to whistle. You cannot do that to your lips. So, in this image, could you please show me where the normal parotid parenchyma appears and where is the tumor? Tell me here, which is normal salivary gland and which is the tumor? Can you discriminate between the two? What do you think? What's the normal area? What's the neoplastic area? This is a case of a pleomorphic adenoma, a benign tumor, which we will discuss. What do you think? Do you remember from histology the structure of the normal salivary glands? They consist of acini, which produce the saliva, and of ducts, which take the saliva and bring it to the mouth. So where are such structures evident? Yes, here. This is right, the normal, this is normal, and there is some amount of fat tissue as well, some amount of fat tissue, and it's not necessarily malignant. However, you can see that the pleomorphic adenoma, its name is due to the various appearing stroma. That's why it's called pleomorphic, because the stroma is strange. It has some areas like cartilage, other areas that look like a mucinous background. So you see that despite being a benign lesion that does not metastasize if it's a pleomorphic adenoma, it has these projections in the normal appearing. You see this projection here of the tumor? You see this? It's not invasion, it's just a projection of the tumor. However, this is clinically important because if such a tumor is enucleated, what means enucleated? You just remove the tumor with no surrounding normal tissue. This is not enough. Why? If you leave that projection within the neighboring salivary gland parenchyma, what will happen? It will recur. So, when you have a fine needle aspiration biopsy, because that's the way to check what the tumor is before the operation, and the answer is it looks like a pleomorphic adenoma, then the surgeon takes into account that it's not enough to remove just the lesion, the tumor, but he has to perform a parotidectomy. Superficial parotidectomy, but he has to remove surrounding normal parenchyma so that any tumor projections in the neighboring parenchyma are removed and the likelihood of recurrence is eliminated. It's very, very low. So this is the most common tumor of the salivary glands, pleomorphic adenoma. And here is the other common benign tumor, which consists of dense lymphocytic infiltrates. It's not a lymphoma. These lymphocytes are benign. And all these cylindrical cells, which are too pink, these are called oncocytes. That means they have an increased amount of mitochondria. This gives them an abundant pink staining cytoplasm. These are called oncocytes. Do you remember what other kind of neoplastic cells, when enough differentiated, has pink cytoplasm? And it's a marker of differentiation. We've seen such neoplasm. Yes? Squamous cells, yes. So another neoplastic cell type with increased pink cytoplasm is oncocytes. These are not squamous cells, but have it in mind. If you see neoplastic cells with pink cytoplasm, you can think of a squamous cell carcinoma, this is squamous cell differentiation, or you can think of an oncocytic tumor, such as the case here. And what do these cells and lymphoid tissue form? They form these stalks with vessels, capillaries, and increased lymphocytic presence. What is this architectural pattern that quite a lot of glandular neoplasms follow? What are these structures? They appear like fingers. How are they called? What is this pattern in a tumor? You have covering cells, here oncocytes, and a stalk with vessels, capillaries, and in this case, dense lymphocytic infiltrates. What is this called? What pattern is this? Some glandular tumors have this pattern. Glandular tumors do not always form glands. Sometimes they form these structures. What is this called? What is this called? Anybody? Yes? Papillae. Yes. So, the old name of this lesion, now it's called Warthin tumor. But the previous term was papillary cystadenoma, because most often it becomes cystic, lymphomatosum, but that was wrong because this is not a lymphoma, not a monoclonal proliferation of lymphocytes, not a malignancy of lymphocytes. These cells are polyclonal lymphocytes, but they are a morphologic feature of this tumor. Benign tumor, mainly. And always, when making an operation, the facial nerve should be spared. Oh, here we have another tumor. It's a malignant tumor, and it has some cystic and solid elements as well. It is deeply infiltrative, and it can metastasize, and in that case, it will be fatal. Have a look at its cells. It's an example of a tumor which has been which is known as, you see, there are tumors that where a sheep and it's a wolf. That means the cells are deceptively benign. Why? Because they are not pleomorphic. So on the first, you do not see that it's a malignant tumor because it lacks a basic feature of many malignant tumors, which is nuclear pleomorphism. Here is an exception to this rule. This is a malignant lesion, but it has homogeneously appearing cells. This is an adenoid cystic carcinoma, which has, you see, the cribriform pattern, which looks like Swiss cheese. I'm not sure of what kind. Anyway, and you see the solid pattern at the bottom, which is of increased aggressiveness. On any account, it's a malignant tumor, it can metastasize, and its benign appearing tumor cells are deceptive. They are not benign. It's malignant. And so how can you be sure that this is a malignant tumor? Since it's not pleomorphic, you have to look for other signs of malignancy, such as nerve invasion. If you see these cells surrounding nerves, this is invasion. So you understand that it's an adenoid cystic carcinoma, and you follow the patient postoperatively very closely. It can give metastasis to the lung and other sites. Oh, have a look at this larynx. What are the anatomical compartments of the larynx? We have the glottis, where we have the vocal cords. Those that are upwards, close to the epiglottic, are false. Those are down, close to the subglottis, are true, meaning that they have muscle. What epithelium is lining the area of the larynx? It's cylindrical, respiratory epithelium, which most often has squamous metaplasia, taking into account that there are some sites of the larynx that the epithelium is normally squamous. So cells coming from this epithelium are either papillomas, squamous cell papillomas, known as laryngeal polyps sometimes. Polyps are not true neoplasms, they are projections of the stroma mainly covered by normal appearing epithelium. However, there are carcinomas, and taking into account what we said, that salivary glands are throughout the upper respiratory, the previous tumors we saw in the salivary glands theoretically can arise there as well, in all the mucosal surfaces of the upper respiratory system. And it's very important when you see an invasive tumor to look at the neighboring normal lining epithelium. If it is dysplastic, it is a sign that it derives from this epithelium, so it is of such a nature, if it's dysplastic. If it's totally normal, it's not so possible. It might be something arising from deeper epithelial structures, such as salivary glands. So you'll take into account. This is not always the case. Remember that we saw a squamous cell carcinoma in the tongue when the lining epithelium was normal. However, that was an exception. The rule is that if a malignant tumor rises from the covering epithelium and you see the neighboring covering epithelium, it probably is dysplastic. It shows some degree of dysplasia, most commonly high-grade dysplasia. So you see that one chord is very thickened. Which is this chord? The right one or the left one that is thickened? What do you think? Yes, it's the right one. And you take a biopsy, you see invasion by malignant cells, and let's have a look at these cells. This could be a laryngeal squamous cell carcinoma arising on a dysplastic squamous or metaplastic squamous mucosa. And have a look at histology. What does the asterisk show? Here we have the biopsy from the right vocal cord lesion. What does the asterisk show? That's the neighboring tissue. And you have the tumor invading downwards. You see cell formations going down. And what do you see? What sign of differentiation can you identify? What's this round structure? Yes?
I was going to talk about the nuclei.
Where do you mean? The nuclei? Here, this is the normal appearing. What is this structure here, the round one, that it has this rectangular? What can this be, which is a sign of differentiation? What can this be? What sign of differentiation in the malignant tissue do you identify? Yes?
Great amount of cytoplasm.
It has pink cytoplasm, so this is squamous differentiation, and moreover, it forms a pearl. This is keratin production. This is a keratin pearl. That means that the squamous cell carcinoma is, at least there, of low grade, so keratinization is evident in the form of a keratin pearl. And what is the prognosis? The prognosis of laryngeal cancer should always take into account its anatomical location, because if it is locating supraglottically on the epiglottis, then the risk of lymph nodal metastasis is increased. So the surgeon must remove what else? Since the risk for lymph node metastasis is increased in in cancers locating on the upper part of the larynx, because there are many lymphoid vessels passing there. So what else must the surgeon remove if he treats? Yes, if he treats a supraglottical tumor, he must have a lymph node, a cervical lymph node dissection, so that we check the lymph nodes in the microscope and see if they are metastatically infiltrated. And this will permit the staging of the tumor. All right? So the anatomical location is of vital importance in laryngeal squamous cell cancer spread. Tumors of the glottis, meaning arising on the cords, the vocal cords, are not so, it's not so possible to give nodal metastasis. It is, of course, it's cancer. However, the prognosis is good. Tumors of the subglottis and supraglottical tumors are more dangerous as far as lymph node metastases are concerned.
Professor,
Yes, please.
where the asterisk is, do we have normal epithelium or is it,
Where that?
where we see the asterisk?
Normal, yes. It's normal.
So below where we have like a
Yes, it's expectedly a low-grade dysplasia would appear.
so
However,
because of the tumor is
yes,
is more dysplasia.
it's not so easy to see if it's a reactive epithelium or a low-grade dysplastic. The discrimination, the discrimination is not so safe. Okay, then, So see you on Wednesday when we start lung pathology, lung cases.